Depression isn't something that we'd like to talk about often, but there is a crisis in South Africa. In January 2019, the South African Stress and Health Study showed that there was a 10% lifetime prevalence of depression amongst South Africans, and that almost 20% of South Africans would experience symptoms of depression at some stage of their lives. Now let's think about the last 2 years and how much that has impacted mental health. In South Africa today, statistics show that 23 people commit suicide. And for every one person whose attempt is successful, there are 10 that aren't. This is where ketamine comes in. It's a weird word, it's a dodgy word. Everyone's a little bit afraid of it because it is a horse tranquilizer. But it is also an anesthetic in horses, and it has been used as an anesthetic on human beings for a very long time. Now imagine that after all this time, there is a treatment for resistant depression, PTSD, chronic pain, and anxiety. Ketamine may just be the answer. I spoke to Dr Lené le Roux, who is a mental health practitioner in Claremont, Cape Town. She explained the ins and outs of ketamine infusion therapy. Thank you for watching, and please don't forget to subscribe. I'm Nadia Swart for BizNews, and I'm joined today by Dr Lené le Roux, who's a mental health practitioner based in Claremont, Cape Town. Thank you so much for your time, Dr. Le Roux. So we're going to talk about something a little bit alternative today, and that's the treatment of resistant depression, suicidality, and chronic pain with ketamine. But just by way of introduction, what is your medical background?
So I trained as a medical doctor at the University of Stellenbosch, obtained my degrees in 2013, and then I did 2 years of internship at Tygerberg Hospital, followed by a year of community service where I was lucky to be placed in a psychiatric hospital. So even my community service year was done just in psychiatry. And then I did 3 years of psychiatric registrar training at UCT after that. And then I started my own practice, and I've been in private practice now for about a year and a half.
What is it about psychiatry that drew you?
It's just something that I've always really found interesting. When I was applying for medicine initially, just after school, I actually applied for psychology and medicine. So I think it's always been a part of what I enjoyed doing. And then when I did my rotations as a student through psychiatry, you rotate multiple times through different sort of specialities. And every time I did a psychiatric block, I just found that I was the most happy. And so I was very fortunate to be able to do my community service in psychiatry and sort of prepare for exams and that kind of thing at that time. So I think it's just a path that I've always needed to follow.
Great. So ketamine, it's alternative. Most people know it as a ill-advised recreationally used drug. It's a horse tranquilizer, if I'm correct.
So ketamine is an anesthetic medication initially. So yes, people do refer to it as a horse tranquilizer, but we also use it in human anesthetics. So for example, if a child was to break a bone and they just need to reset it in the emergency unit, instead of going under full general anesthetic, they'll administer some ketamine to the child and reset the bone in that way. So it's been used for many, many years as an anesthetic medication. And we don't use it at those kind of doses when we treat depression. We use much, much lower doses. So but its original use was as an anesthetic.
All right. So can you just explain to me the process behind your decision to say, look, this myriad pharmaceutical drugs are not doing the trick, and there are literally, countless amounts of drugs out there. What was the mental process behind deciding, let's try something new?
So I think that it's something that has become more and more accepted within the psychiatric sort of fraternity over the last few years, because there's more research that's been published on it, and we actually have now got more treatment guidelines and that kind of thing that are evidence-based. And I think we all, as practitioners that work in mental health, become very, concerned about our patients when we've tried multiple different drugs, we've tried different classes of drugs, we've tried augmenting with things like antipsychotics, and we just hit a wall where some patients just don't respond. And in the past, that would sort of mean that somebody would suffer from chronic depression. But now that we have access to ketamine, it's a really great extra tool in our toolbox that we can use when we hit that wall. It doesn't necessarily need to be a patient that has been struggling with depression for years. It can be somebody that's more acutely depressed, but isn't responding adequately to medication, or if there's a very high risk of suicide. So people sometimes refer to ketamine as like the anti-suicide drug. Because it shifts suicidality very quickly. So we use it sometimes in that sense as like an emergency measure, but we also use it in patients that have had long-standing chronic depression.
And when you say shift suicidality very quickly, how long a time frame are we talking?
So the first antidepressant effects of ketamine is seen within 24 hours after your first injection. So it's really very quick. We usually do a treatment series of 6 sessions that take place over 2 weeks. So it's quite intensive. You come Monday, Wednesday, Friday for 2 weeks. And usually by session 3, there's a really big shift that you can clinically see the patient is looking better, they're feeling lighter, those dark thoughts are starting to go away. And then the rest of the sessions are really to consolidate that and to get them completely better.
But this is outpatient care.
It's outpatient. So there's different clinics that function in different ways. Some of the inpatient clinics do offer ketamine that are administered as part of their inpatient treatment. But the way that I work is just as an outpatient basis. So I use the intramuscular injection. So it's just an injection in the arm, which means that you don't need all the equipment and resource equipment because there's very, very low risk. And it's used at such low doses that it's so low risk. So we do it as an outpatient. Patients aren't able to drive afterwards, but they usually just take an Uber. They're absolutely fine and conscious and everything to take an Uber back home. And it's actually such a nice thing that's been made available recently.
What is the time frame for this? Is it a temporary sort of treatment? So basically my main question is, will patients have to eventually administer it themselves? Is that not perhaps a risk associated with abuse of the drug?
Yeah, so we do the initial treatment of 6 sessions, and then it's very patient-based. So if they didn't go completely into remission within those 6 sessions, we'd recommend a few top-ups, usually 2 to 3. And then each patient's sort of longevity of their ketamine response is very different. So sometimes after a couple of months, we might need to do 2 or 3 sessions again just to get them back on track. It's not something that I think will ever be home administered because there is a potential for abuse. So S-ketamine is a form of ketamine that is going to be launched later the year in South Africa, and that's a nasal spray. But it will also need to be done under complete supervision and guidance by a doctor.
Okay.
So there is a potential of abuse with ketamine because it is, as you know, used as a recreational drug. However, we don't really see that in the clinical practice when we administer it under supervision. There have been cases, of course, where patients sort of start seeking the medication, and that's when you terminate treatment and you actually say, unfortunately, we won't be able to continue. I haven't had that experience myself, but I do know that there have been isolated cases. And when I looked, I was part of a conference recently with sort of an international ketamine conference that looked specifically at infusions, intravenous infusions and S-ketamine. And they also found that addiction really wasn't a big problem within their practices. Yeah.
So it's not physically addictive, but it does have mentally and emotionally addictive risks.
Yeah, it's enjoyable. It's an enjoyable experience most of the time. So there are patients that start to seek that pleasure. It's not something that forms addiction as in that you have withdrawal symptoms or that you build tolerance to it, which is a bit different to other drugs. And it's actually used, one of the indications for ketamine is substance use disorders. So people with alcoholism, cocaine addiction, that kind of thing, have found that they have reduced cravings if they have had a few sessions of ketamine. So it's actually used in helping patients get off other recreational drugs.
That's incredible. I really had not heard about that before at all. Has this kind of research made you consider the treatment of depression and other disorders with other alternative therapies like mushrooms or?
Yes, so psilocybin, which is mushrooms, is being researched extensively at the moment internationally because it has been approved for the use in depression in other countries. The protocols are still being developed as to how one would administer it, and it's often used as part of a psychotherapeutic intervention. So patients will actually have therapy sessions preparing them for their psilocybin dosage. They'll then have psilocybin under the care of a therapist, have a few more sessions, have another session of psilocybin. So there is a protocol being developed, and they are having amazing results. So I think it is something that's going to be available in the future here as well. Once that research is sort of finalized and the evidence is there, hopefully it'll be available to the South African public as well.
And regarding ketamine, you mentioned later in the year that there will be a nasal spray, but what are the legal challenges that you're facing to decriminalize a substance like this for therapeutic purposes?
So it's not criminalized at the moment. It is legal. It's off-label use. So ketamine is a legal drug to be used by doctors, but it's off-label use for depression still. The S-ketamine is hopefully going to be on-label use. And it has been approved in other countries. So it's something that medical aids might even end up paying for, which at the moment they don't pay for ketamine treatment for depression at all. But once it's become on-label use, they will probably start funding it as well, which will be great. Because S-ketamine, the nasal spray, is extremely expensive. It's about 3,000 Rand per spray, and for one session you sometimes need up to 3 sprays. So that would be like 9,000 Rand a session. So it's not going to be something that's accessible if medical aids don't pay for it.
And what hurdles do we face? Are there any groups advocating against this?
Not that I'm aware of. I think that there are still people that are a little bit suspicious about ketamine. You know, even within the psychiatric community, there are people that are not using it yet, or not referring patients for ketamine treatment yet. But I think that once people have had patients get ketamine and seen how robust that response is, it just gets used more and more and more. I've had that experience in the last few months where I get referrals from psychiatrists and they say, you know, would you administer for my patient? And they see how well it works, and then they just send more and more patients because it's just such a great tool. And yeah, I think it is going to definitely gain traction over the next few months.
And if you can just provide me like a ballpark statistic in terms of patients that fully recover and those that need to sort of come back. Just overall, how positive are the results?
So the results, I can't give you the exact statistics now. Sorry, I don't have them on hand, but they are extremely positive, and there's a significant improvement in people receiving ketamine versus people receiving a placebo. So, for example, the trials are done, they usually administer something called midazolam to the patients who are not getting ketamine. So it's a benzo, it makes them feel sedated and as if they've had the drug. And the people's sort of depression scoring after receiving ketamine is significantly reduced compared to those that had the midazolam. And just in my own practice, the patients that I've provided ketamine for this year, out of everybody I provided ketamine for, I had one patient that didn't do as well. She managed to reduce her suicidality, but she has very severe borderline personality disorder. So there wasn't a very good prognosis from the start. The patients I've seen for treatment-resistant depression, anxiety, bipolar depression have all done extremely well, remarkably well. And these are patients that have been struggling for years, and they had their 6 sessions of ketamine and they're better. It's just so wonderful to see.
And these results, when you say better, does that mean that they can discontinue use of all the pharmaceuticals that they've been prescribed prior to this treatment?
So we try not to do that. You know, there is still a place for the traditional pharmaceuticals. They treat a different part of the brain. So your traditional antidepressants target serotonin, noradrenaline, and dopamine, whereas ketamine is an NMDA receptor antagonist, so it works on glutamate in the brain. So we don't discourage that patients we don't encourage that patients stop their other medication. We continue their other medication, but there have been cases where we're able to reduce the amount of medication that they're using, especially for patients that are coming with anxiety disorders and that are very dependent on sedatives. We managed to get the sedatives reduced, so they're not using as many sedatives during the day because their anxiety is better. But there's maintenance treatments we do continue.
Then just to close off with, what is the sort of the range of disorders that you foresee ketamine being able to assist with?
So at the moment, we use it mainly for treatment-resistant depression, and that's for people with major depression as well as bipolar depression. So there's actually been the most research done in bipolar patients with depression, where there's a risk of starting when you start an antidepressant. So a bipolar patient, if you start an antidepressant, can become manic and sort of go to the opposite spectrum, whereas ketamine doesn't cause that mania. So it's a safe way of intervening for bipolar depression. Then all the anxiety disorders, social anxiety disorder has really good results, generalized anxiety disorder, OCD. So those are the anxiety disorders we target. And then PTSD is another one where there's really good research for the treatment of PTSD with ketamine. Chronic pain is something that's it's also used for, a little bit controversial amongst doctors whether it's something that we should be using or not, but it makes the brain more susceptible to opioids, so it actually helps the medication that patients take for pain work more effectively. So it is used for that as well.
And then, sorry, just that just leads me to one other question. Is this used in conjunction with any sort of psychotherapy or psychological assistance, just to sort of contain, so it doesn't feel like you have the substance and then you just go forth into the world and there's this juxtaposition of sorts?
Yeah, so unfortunately, ketamine-assisted psychotherapy is it's not really available at the moment. There's one clinic that does offer it, but it's very expensive because it's quite time intensive. And obviously you need a psychotherapist then present. How I do my sessions is that I do sit with the patient before the time, reflect on what we're doing today, set an intention for the session. So whether that is just having compassion with themselves, whether that is focusing on the healing that's going to happen in their brain, whatever comes up for them and their intention we focus on. And then afterwards we spend 10 minutes just sort of debriefing about the session. What did they see? What did they experience? Is there anything specific that came up? And so that they leave also just feeling like they've had time to process the session. So of course I'm not a trained psychotherapist and that's not my speciality, but I do offer some sort of counseling support in that sense at each session. Yeah. And patients have their own psychotherapists as well. So they continue to see their psychotherapists privately while they're doing the ketamine treatment. So once a week, twice a week, they see their therapist as well. And I'm usually in contact with their therapist during the time as well.
So there is a holistic sense of treatment.
Yeah, definitely.